How's everybody doing out there? It's Dr. Gillard. It is Thursday, week 7, CVPP. How'd you like that GIGU test? I hope you enjoyed that. That's some hard stuff, right? That endocrinology in particular. Here we go. No class Monday, right? That's the holiday. I'm greatly looking forward to a 3-day weekend. All right, we left off on coverings of the heart. So that would be the pericardium, right? And yeah, there's the pericardium. There's a really nice picture of it. Kind of a see-through sac around the heart. Notice right here, notice how it contains the root of the aorta. So that's important, right? We talked about dissections, Stanford A dissections that can rip. What do you think happens if you get a leak inside there? I'm already going off my script, my slides, but that's okay. Yeah, if you get blood in here, what's going to happen? This thing's going to stretch out, but it's not going to stretch very much. You can strangle your heart. That's called cardiac tamponade. So we will be talking about that today. But it does contain the great vessels. You're not going to get aneurysms or bleeds in the pulmonary trunk or superior vena cava. Interestingly, with regard to the great vessels, the inferior vena cava is not included in the great vessels by most authors. So that's a little weird. But yeah, those are the great. Pulmonary veins are also included. You can't see them, but there would be behind this coming into the left ventricle. And yeah, there's the pericardium. We'll talk more about that. There's a blow-up view. In fact, you can see a couple of the pieces. Remember, the pericardium there's a fibrous pericardium, which is collagen. It's very strong. You can't normally pull it. Remember, in lab, I had you guys grab it and pull on that thing just to show you. Remember, it was also really slippery, right, on the inside. So that is the serous pericardium. We have 2 layers. We have a parietal layer, which is stuck to the fibrous pericardium. And then we have a visceral pericardium, which is stuck on top of the heart. You can't really see it, but it would be covering all this stuff. There would be a thin film covering all this stuff. I'm going way off my slides, but yeah, so there's 2 layers, but both of those are serous cells, so they secrete serous fluid. So you get a slippery, that's that slippery stuff that you felt on your gloves, still, after the heart hasn't been beating in many years probably. It's still there. What's this? Ligamentum venosum? No, where's ligamentum venosum? That's in the liver. Ligamentum arteriosum. Right? Ductus arteriosa. We talked about that last week. Anyway, I digress. So everything I said, it's a tri-sac. It's made of 3 layers, a fibrous, serous. Serous is broken down into a parietal, which is stuck to the fibrous. The parent and the fibrous are stuck together. The child went off and surrounded the heart. And importantly, there's a cavity between the parietal and visceral. Did I say visceral? Parietal and visceral layers of the serous pericardium. That's really important. We're going to talk a lot about that. That's the pericardial cavity, which you can see it right here in this picture. And that is where that little slippery stuff, not very much of it, is in there, but it does kind of make the heart slippery, so the heart doesn't start to get rubbed raw from beating within its sac. There's another picture of it, kind of blown up. Right? Be filled with a serous pericardial fluid, serous fluid. Okay, not too much normally. Then right under that, there's the visceral layer. There's the parent, parietal layer. And the parent, parietal, and the fibrous is stuck together. This is really when the author kind of messed this up. This is not double layered. To my understanding, most authors say this is just single layer. So, all right. You can also see how it kind of does a loop back here. And there's the ascending aorta right here. or I guess it would be, this picture's a little messed up. Oh, you can see it there. Yeah, but that is the ascending aorta. So it does encompass the ascending aorta. So if you get a bleed right here and spring a leak, you got all that blood flowing out. Right, fibrous, we talked about this. Outermost layer of the pericardium, very tough, very fibrous. It's not immediately, what do I mean? It's not immediately stretchable. What do I mean by that? I mean, if we grabbed it like we did in the lab and pulled on it, nothing happens. It doesn't stretch. However, if you slowly apply pressure to it over long periods of time, it will grow and stretch. So it can stretch in conditions which ooze fluid into the pericardial cavity, but not ones that gush fluid like a hemorrhage. As we said, Stanford A dissections, as well as DeBakey 1 and 2. Right? Anything that causes a hemorrhage of the root of the aorta, you're in trouble. You'll get a buildup of fluid, and that's called, within that pericardial cavity, and that's called cardiac tamponade. We'll come back to that one. And now, oh no, not these things. We just got tested on these things. Oh yes, they are back. Make sure you know this slide. Know the different types of dissections. Stanford A means that it has to at least occur in the ascending aorta. Doesn't care. Still a Stanford A. It might go creep into the ascending arch. Still a Stanford A. Might creep into the descending aorta. Doesn't matter. It's still a Stanford A. Very general. Now, if it doesn't involve the ascending arch or ascending aorta and starts in the ascending arch, Stanford B. Maybe it'll progress into the descending aorta, still Stanford B. Maybe it just starts in the descending aorta, Stanford B. Got it? DeBakey 1, 2, and 3, we've talked about these before, right? DeBakey 2 is easiest to do. That is only, though, DeBakey 2 is only a dissecting aneurysm in the ascending aorta. Is a dissecting aorta a saccular or is it a fusiformal aneurysm? No, it's neither, right? Those are true aneurysms. There's no rip. To have a dissection, you have to have a rip in the tunica intima, or you have to have a rip in the tunica media from a vasovassorum injury. So those are false aneurysms, so it's neither. So make sure people screwed that up. I can't remember if it's our last test or people screwed that up. So, all right, DeBakey 2 or DeBakey 1 means that the ascending aorta is involved and at least the arch is involved, or something else has to be involved. It can't be isolated to the ascending aorta. If it's anywhere else, it's a DeBakey 1. If it's isolated only in the ascending aorta, it's a DeBakey 2. If it doesn't involve the ascending aorta or the arch, it's a DeBakey 3. What if it just involves the arch only? What if it's right here? There's no DeBakey description for that. Fibrous pericardium, we said it's highly resistant to a rapid stretching type motion. So as I said, it doesn't stretch if you pull on it. It can stretch if you slowly fill it from blood, but big trouble if blood comes rushing into it, right? Because it won't expand and you'll crush the heart. And we said that's what condition? Cardiac tamponade. So there's Homer strangling Bart. And that's like the fibrous pericardium that's filled up with blood. Literally crushes the heart, as we will talk about right now. So because the fibrous pericardium doesn't stretch, it can compress the heart. We've talked about blood. Are there other things that can compress the pericardium? Yeah, pus from an infection. Or from an inflammation, I could have put just as easily. Pus from inflammation. So Now, we'll talk about that in a minute, so I'm not going to go crazy on that. I started, I might as well put that at least. Pus, inflammation, serous fluid. So if you get an inflammation, it'll stimulate the serous cells to, when they're stimulated, they overproduce their fluid, so it's serous fluid. And then when the myocardium becomes compressed, you got yourself cardiac tamponade. There's a cartoon of it. This is all filled up with serous fluid. It looks like, doesn't look like blood, but it could be blood, it could be pus, it could be anything. It's starting to push into this heart and put pressure on it. We'll see exactly how that works in a second. Normal or abnormal, as I take some water here. That's a beautiful looking chest film, isn't it? Completely normal. Nice normal size heart. Hemidiaphragm. Costophrenic angles, you always check those to see if there's any fluid. They should be sharp. They are very sharp. Looks great. How about this? Doesn't look good. Look at the difference between that heart and this heart. It's way blown up, and that's because this patient has chronic pericardial effusion. It's causing cardiac tamponade. Serous pericardium, we already said that. It's a double-layer sac. I guess we need to make it official. It's made of a parietal layer. And this is the one that sticks to the fibrous pericardium. I can't separate them apart. And then there's the visceral serous pericardium. Cardiology, you don't call it that. That's using histology. You call it the epicardium. But really, that's an AKA for the visceral component or visceral layer of the serous pericardium. And that adheres to the heart, the outer covering. Covers the top of the coronary arteries, coronary veins, any autonomic nerves. Heart is encased by that. Lymphatics, fat. It also folds backwards. Remember that picture, how it folded backwards on itself to create the pericardial cavity, as well as some other sinuses. I think I took those out of there. We don't need to worry about those. It's also just like the parietal and the visceral are both made out of serous mesothelial cells, which secrete fluid, specifically serous fluid. And then we said there's a pericardial cavity between there. Very important. This is a potential space, meaning that it's not very wide normally, because there's only 30 cc's. Remember, cc and milliliter are AKs for each other. It's only 30 cc's of serous fluid there. That fluid is called pericardial fluid, and it's just like pleural fluid around the lungs. There's a pleural cavity, and there's a peritoneal cavity or peritoneal cavity. Tomatoes. And there's a peritoneal fluid and a pleural fluid as well. Same story. Serous membranes, they both secrete some slippery serous fluid to kind of to mitigate any buildup of friction. And that's where I just said already, the fluid acts as a lubricant to minimize friction between the hearts. Normally there's a little pressure in there, and that's not very important. It's plus or minus 5. It's actually minus 5 in inspiration. Everything turns negative. There's a sucking force going on. And then it's positive during expiration. That's not really clinically important for us, though. We looked at that picture already. What are the 3 functions of the pericardium? Well, it holds the heart stationary within the mediastinum. So we don't want the heart flopping around, so it's anchored. So it anchors the heart. It also prevents the heart from overdilating. If you passed a gigantic blood clot through there or something, you don't want it to explode. And so it prevents it from overdilating. And some research used to say that there's a barrier function. People with pneumonia never get peritonitis. Well, I shouldn't say never, but they usually don't get peritonitis. And they thought the reason for that was because the pericardium, the fibrous pericardium mainly, because remember the lung tissue sits right on top of the heart. So why doesn't someone with an inflammation of the lungs get an inflammation of the pericardium? And the theory was because the fibrous pericardium didn't allow that to happen. However, that research, and that's what board books still say, but research says they followed people who've had heart transplants. So that brings me to a question. If you've had a heart transplant, if you've had a new heart or an artificial heart put in, do you have a pericardium? No, you don't have a pericardium, right? All those nerves are gone. There's no communication to the heart. That's all been removed. And so the research on that in people with pneumonia, they don't get an inflammation of the heart, and just because, like, it'd be a myocarditis, right? They don't have a pericardium, but it doesn't seem to spread to the heart. So, bottom line is that's might be a wives' tale. All right, let's get to some disease. I always like disease. When you're studying for my tests, I always study diseases first. Those are the most important. Acute pericarditis. Guess what that is? What's that mean? Very good. That's an inflammation of the pericardium, and that's exactly what happens. It's actually the most common disease or affliction or condition of the pericardium, and it's just an inflammation of the pericardial layers. Typically involves all three. It's also because the pericardium does have nerve fiber, nociceptive fiber within it. It can certainly cause pain if you get an inflammation of the pericardium, pericardial sac, and so you can present with a pain very similar to that of heart attack. And so about 5% of the patients coming into the emergency room with chest pain turns out not to be a heart attack. It turns out to be acute pericarditis. What else can cause that same type of precordial pain? Or that peristernal or upper sternal pain? GERD, gastroesophageal reflux disease. Yep, so those are strong differential diagnoses. There's two general causes of pericarditis. There is infectious and non-infectious. However, important to understand, no matter what the cause, inflammation is at the root of this problem. It's still a pericarditis, right? It's still an inflammation. And I mean, basically, if it's infectious, a bug causes the inflammation. If it's non-infectious, something else triggers the inflammation. Just look at infectious first. So yeah, just bugs, right? And bugs get into the pericardial cavity and the body sees them. It's richly innervated, has blood vessels and nerves. Body spots those bugs, sounds the alarm, and here comes the troops. And now you got yourself an inflammation of the layers of the pericardial cavity, right? Serous pericardium, fibrous pericardium, all inflamed. And it oozes. When cells get inflamed and irritated, what do? They can do two things. They can either stop doing what they normally do, or they can overdo what they normally do. In this case, they overdo what they normally do. And what do serous pericardial cells normally do? They secrete serous fluid, and that's what they do. Inflammation causes them to overproduce fluid, and you start to get a buildup of serous fluid in the pericardial cavity. The inflammation may also produce some pus and gross exudate stuff, and that can start to pile up in the pericardial cavity as well. And as fluid builds up, you start to get cardiac tamponade. It starts to squeeze that heart, the worse this problem gets. Who exactly are the bugs? Well, the usual suspects: virus, bacteria, staphylococci, pneumococci, tuberculosis. The most common, they biopsy, they take some fluid out of the pericardial cavity that's built up, and what do they find? Nothing. and they think it's probably a virus that they just didn't recognize. But idiopathic is the most common type of pericarditis. They can't find a cause for it. So it's thought to be a virus that just was not detected. I do like this question. Non-infectious pericarditis, so it's got to be an inflammation of the pericardial cavity caused by something other than bugs. So its most common cause is thought to be an autoimmune attack of the pericardium, of the serous pericardial cells. So the immune system all of a sudden doesn't look like the way that pericardium looks. Why do you think that would happen? Well, something has stuck or invaded those cells, those serous pericardial cells, which create the pericardial cavity. Something's gotten in there and gotten into the nucleus and flipped on some new genes. And so now those cells are expressing markers that the body doesn't like anymore, and it attacks those cells. So it's like an autoimmune, but something's got to trigger it. Okay, so there's some other weird stages or other weird causes. People who have myocardial infarction, we'll actually look at this one a little more closely. But people who have a myocardial infarction, if you have dead myocardial tissue, what happens to that tissue? Does it just stay there? Of course not. It has to be cleaned up. And what's the process that cleans up dead tissue? Oh, an inflammation. Yeah, so there's your inflammation again, and it could inflame the pericardium and cause pain. This is a weird one. So this one's only seen in end-stage renal failure. And not all types of renal disease can do this, but many, when the kidney is really, if it's full of cancer or if it's being destroyed by something and breaking down, fragments of the breakdown products from the kidneys can start to get loose in the bloodstream, and they float around. And why they get stuck in the pericardium, we don't know, but they do tend to like to get stuck, especially if there's azotemia. You know what that is? Azotemia means there's really high bun. There's lots of nitrogen products circulating around in the bloodstream. You do a blood test, that's blood urea nitrogen levels are increased. So we don't know if it's the nitrogen level that's triggering the autoimmune type response, but whatever it is, it's irritating the cells of the pericardial cavity, and those cells are calling in the troops, and an inflammation ensues. So if it is failing kidney, that's called uremic pericarditis. And look at quite a few stars here. Lots of stars. All three corners are filled up. So I do like this slide because I don't think you know the words azotemia, and uremic pericarditis, but now you do. All right. How about even more causes? Cancer. You can get, let's pick a cancer. Malignant melanoma gets into the blood, and the cancer cells fly through the body and land and keep mutating. And they can get into the pericardial cavity and get into the serous pericardial cells. And a cancer can start in there, and it irritates even the mutated cells start secreting serous fluid, and it irritates the native cells, and they start secreting serous fluid. And now you got yourself a buildup of fluid in the pericardial cavity, and you can go to tamponade. Radiation inflames the cells. It just damages the cells to the point they release cytokines, which call in the troops to clean up the dead ones, and you got yourself an inflammation because of radiation, probably from cancer. Inflammatory diseases like lupus, systemic lupus erythematosus, rheumatoid arthritis, scleroderma, they can all inflame different. They all have their favorite targets, but the pericardium all three of these can hit the pericardium. All right, let's go back to this heart attack thing. So let's talk about heart attack. It's kind of a weird thing. So there's two types of pericarditis that can occur following a myocardial infarction. There's the early onset, which occurs few days after the myocardial infarction, the death of myocardial tissue. and a delayed onset. Talk about the early one. So this occurs a few days after the myocardium. As I said before, the dead myocardial tissue becomes inflamed and it has to be cleaned up. The inflammation moves out of the cleanup process and goes, oh, here's some tissue, let's get into that. And because we know that the pericardium is right next to the epicardium or serous pericardium, visceral layer if you want to get specific. And so the cleanup inflammation spreads into the pericardium. Now you got yourself a secondary type pericarditis. I like that word. I'm surprised no others use that. That's my word. Secondary pericarditis, but I like it. More common in myocardial infarctions that encompass large areas, small superficial MIs that are very close to the pericardium. If it occurs superficially in the myocardium, they tend to get these as well. And I like this slide. I could have put some more stars on this because I do remember asking this question just about every quarter. Put some for you there. What is it's not, so how, this can be deadly, this one. And it's not because the inflammation is going to kill you. But what's deadly about it is people who have one heart attack have a great risk of developing another heart attack within the next couple of weeks. And the trouble with pericarditis, which is fairly common after a heart attack, it hurts. And it can mask, the pain of pericarditis can mask the pain of a second myocardial infarction. And therefore the staff just thinks, or the patient maybe, it's just the pericarditis. I'm not having a second heart attack, but sure enough, patient dies. Autopsy finds they had a second heart attack, and the symptoms were masked by the pericarditis. Everybody got that? Now this was another weird one. This is a late type associated. So, it's kitty hour again. Sorry about that. I don't know if you can hear it. You could probably hear it. Why they like to play under my window, I just don't know. Anyway, and it's not that I don't like kids, right? I have 5 kids and we have 11 grandkids. It's just I like to, I get in the zone when I'm lecturing. I get distracted easily, I guess. Anywho, Dressler syndrome. I do like that word. Dressler syndrome. That's an AKA for late type MI-associated non-infectious pericarditis. You think they're going to write a question like that on boards with that word? Plus it tells you it's a pericarditis. No way. They're going to say Dressler syndrome. Easier to write, and it's a better, more challenging question. So this typically occurs maybe 8 weeks after a myocardial infarction. On average, about 4 weeks, patients have a reoccurrence of chest pain. They come back into the ER thinking for sure that they had another myocardial infarction, and it's not. It's a pericarditis, and they have Dressler syndrome. The etiology is not known. You would think the cleanup would be done of the inflamed tissue, but we don't know. One theory is the new cleaned up dead myocardium, some genes got turned on in the cells adjacent to the dead area, and now the body doesn't recognize that and starts an inflammation against that. But they really don't know for sure. But they do know they can have really bad pain because they have a pericarditis again. So that's Dressler syndrome. Comes on late, 5 weeks after myocardial infarction. What are the clinical symptoms of any type of pericarditis? Acute pericarditis, Dressler syndrome. Not sure acute is the best. Even if Dressler syndrome is acute because it comes on anew again. So pleuritic chest pain, we've already talked about that. Remember embolisms, right? That's a sign of embolism, pulmonary embolisms. You got to be careful with that one. They take a deep breath, and it's like someone stabbing them in the chest with a knife during inspiration. Really, really hurts. Coughing really hurts. If they sit up and lean forward, it actually feels a little bit better. So they tend to be like that, or curled up in kind of the fetal position on their side if they can't sit up. It's not uncommon to have a fever, dyspnea. It hurts to breathe, so they have labored breathing, not because there's anything wrong, because it hurts to inspire. And the auscultatory exam, friction rubs, we just talked about, they're right in our lab this week. They can have friction rubs. It sounds like, I don't know if you can hear that. I'm rubbing my hands together. It really sounds like that. There's a couple links. I won't take time to play that for you, but you can check out what that sounds like. But yeah, and it's auscultated at the base of the heart or at Erb's point. I think I said the base of the heart in the lecture, but Erb's point hears the base of the heart equally, so Erb's point and the base of the heart makes sense. And it's like a grinding or rubbing sound. And yeah, that's a friction rub. And it can be a pan auscultatory sound, meaning that it occurs, here's lub-dub, 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 and you can hear it, this scratchy sound, maybe masking the lub-dub, or kind of makes it very confusing type sound. It's usually kind of over the top of it. So it is considered an extra heart sound. We're considering it a murmur. I'm just grouping all abnormal heart sounds into murmurs. Cardiologists there's breakdowns of that. We don't need to get into that deep. It's best heard with the diaphragm. It's a very high-pitched sound at Erb's point or the base of the heart. Don't forget remember in the lab yesterday, I might ask you to examine the base of the heart. The patient has to sit up and bend forward, and then you auscultate either Erb's point or the aortic and pulmonic valves, second intercostal space, right and left peristernal borders. So when it's fully developed, it can mask all the normal heart sounds. So you might not even hear a lub-dub, lub-dub. You might just hear that sound. Okay, some say it sounds like leather. It muffles the S1 and 2 sounds. Breathing in can accentuate the sound, taking a breath. All right, there's our apex monkey area, or all pigs eat too much area. Make sure you know that. We talked about that. But remember, the base of the heart is nothing more second intercostal space on the right and left peristernal borders. This is the base, the clinical base, not the anatomical base, right? We have to go in the coronary sulcus with a little knife and cut through the coronary sulcus and pull off the atria, and that's the base of the heart, the anatomical base. This is the clinical base of the heart. And of course, Erb's point is third intercostal space, left peristernal border. Pericarditis versus myocardial infarction. How do you tell them apart with regard to pain? People with myocardial infarctions don't usually have pleuritic pain. So they can take a breath in and it's not like someone's stabbing them. It doesn't always work that way, but that's a pretty good rule of thumb. So think pericarditis. Strangely, and I mean, myocardial infarction, we'll get to that. But that's like a patient, the elephant is sitting on the patient's chest. All right, you have to be careful with EKG. So you would think, how can pericarditis cause a EKG abnormality? But it actually does, believe it or not. It causes ST segment elevation. I've got to think of my time here. Oh yeah, I'm good. Plenty of time. Probably go short today. We're all burned out from that test. You guys are burned out. I'm burned out too, because I had to write the darn thing and I had to get up at 5 this morning just to read through it a second time to catch any errors. Always read through in the morning. I always catch a couple errors. I don't think there were any errors on this test, but I did catch a couple. Anyway, let's see. So ECG is abnormal in 90% of patients. And how is it abnormal? ST segment elevation. Well, ST segment elevation is, you remember that? We're going to look at it in a minute here. But what's that? P wave, Q wave, the first down deflection, R wave, the first flexion above the isoelectric line, back to the isoelectric wave, up limb, down limb. S wave is below. That's the up limb, or that's the down limb. This is the up limb of the S wave, Serous complex. Right, then we got that interval, and then the T wave. Oh, that's way too big. This is why I don't draw. But yeah, so with a STEMI, ST segment, this will be way up here. Right, this won't come down this far. I don't know why I'm doing this. I got a good picture over here in a second. But yeah, that's a STEMI myocardial infarction. So you have to be really careful with it. And what's the other? I could have added. When we get heart attack, might as well add it right now. How else can you differentiate pericarditis from a myocardial infarction? What test do you order? Troponin. Right? We'll look at the different types. There's 2 types of troponin. There's other tests you can order, but always get troponin levels, and that will tell you they should not be in the bloodstream. And they're only if the heart myocardium is damaged, these enzymes are released from exploding and damaged cells. So. Okay, here's a 60-year-old with pleuritic chest pain and dyspnea. Oh, this is coming. I do like my EKG stuff, and I've learned Dr. Doe has prepared you pretty well. Much better than, you guys do a lot better than you used to do on it. See it? Always look on limb lead 2. Right? You can see limb lead 2. See the 2 right here? That's usually the rhythm strip. So those are the limb leads, or those are the chest and limb leads above, but they always let one run down here so you can look for palpitations or abnormal beats, premature beats. But yeah, let's look at so there's the Q, there's the R, and it doesn't even, there's nothing below. Where's the S wave? There's really no S wave. So that's ST segment. The ST segment is elevated. It's ST segment elevation. Okay, see it? This should come back down to here, right? At least down. It should go below the isoelectric line. This is the isoelectric line. Right there. That's the ST segment, but that's the kind of the base where this is. So it didn't. It's elevated. There's the ST segment. All right. Did I call that the wrong thing? The Q. This is the R wave. I hope I didn't call that the wrong thing. And that's the S wave. The S wave didn't come back to the isoelectric line. ST segment elevation. I should just jump to the picture, shouldn't I? But yeah, there's normal. There's a much better one than I did. There's a Q. This is the up limb of the R wave. This is the down limb of the R wave. Right? Then we go below. Here's the isoelectric line here. ST segment is normally part of the isoelectric line. That's like the base. There's after the T wave, TP interval, if you will. No Q wave in this one. But yeah, so S wave is below. There's a little tiny down limb, and there's an up limb. Then we have the ST segment. And here we can see that there's the Q. There's the up limb of the R wave. There's the down limb of the R wave, but it never got back to the isoelectric line. So that is called ST segment elevation, and that is trouble. Don't see that normally in people. Pericardial effusion and cardiac tamponade. So pericarditis versus pericardial infusion. Let's talk about this. So we just talked about pericarditis. As I said, with any type of pericarditis, there's going to be some inflammation, some irritation of the serous cells that make up the pericardial cavity, that line the pericardial cavity. When they get upset, they overproduce serous pericardial fluid, so you are going to accumulate. And it's considered abnormal once you get over 50 milliliters of pericardial fluid in the pericardial cavity. Now you have a effusion. You have a pericardial effusion. Not tamponade. It's not enough to cause tamponade yet. It's not enough to strangle anything. But let's look at tamponade. If it's a wicked inflammation process, like some viruses and things like that, or anything, but really bad bacterial infection, it can secrete tons of fluid to the point where it does start to strangle the heart. And the number is about 200 milliliters of fluid to strangle the heart. And so it can get much more than that. As we'll see, liters. Or not liters. Is it liters? I forget how big it can get. And I think 1.5 liters. I think we got a picture of one coming here in a second. But that's a problem. And it's a diagnostic problem. And pus, we said pus in there, and blood, and a mixture of serous fluid, pus, and blood. They can all be in there mixed together. So we've talked about this. There's Porth's, I got a slide from Porth's Pathophysiology. I really like this author. I don't think she quite goes deep enough. I think physical therapists actually use this for their, some of them use this because she is a physical therapist, I believe, if I remember right. She's a really good storyteller, much, much better than Rubens and Robbins. You can actually get a good story by just reading her. But the trouble is she doesn't go deep enough into things. And maybe that's probably by purpose. But that's a great book. Anyway, so she explains about rapid versus slow. And I've already said this. If the fluid within the pericardial cavity builds up rapidly, you get cardiac tamponade. It doesn't give the fibrous pericardium time to adapt and stretch out. But if it's a slow buildup, so even in a fast buildup, 200 milliliters can cause trouble. If it's really rapid, if like you've sprung a leak and you had a Stanford A that's ruptured and you're leaking, that's enough to cause cardiac tamponade. But on the other hand, if it's a slow buildup of fluid from an infection, you can get that thing up to 2 liters. I had to check my brain on that one. 2 liters sounds like a lot of fluid, but yeah, there's some. We'll look at a big picture here in a second. So how does cardiac tamponade affect the heart? Remember the heart, when the heart beats, like here's a heart. When it beats, like when you contract your bicep, what happens to your bicep muscle? Right? It gets really big. There's your arm. Oh my gosh, this is like terrible. Trying. But it gets big when you contract your arm. That's not true for the heart. It actually gets smaller. Right? The diameter decreases when systole occurs. And it actually bends, the apex of the heart bends and pokes into the fifth intercostal space left midclavicular line. It pokes right there and causes an apical impulse. So this is not a systolic problem. Tamponade, or crushing the heart, is not going to interfere with systole at all. The trouble is when it starts compressing more, it doesn't let the heart expand, because when the heart relaxes, those chambers have to fill up with blood, and once you get to a certain point with tamponade, it's not going to let that happen, and so you're going to start getting a underfilling of the heart, right? And then you'll have a decreased ejection fraction because the ventricles can't expand enough to accept the incoming blood. It also acts as a beaver dam too. So if you can't get all that blood into the heart, it's going to start backing up into the lungs and even into the right side of the heart. What's the classic sequelae of tamponade? So decreased ventricular filling, so decreased ejection fraction. So there goes your blood pressure, right? If you can't fill your heart up, you're not going to be able to eject enough blood. You can get hypoxia, hypovolemia, the R2A system, so you have increased levels of renin I could have added in here. I should have had that in there, shouldn't I? Increase renin levels. I'll make a note to do that. 215 renin. All right. And it can get so bad. I mean, if the heart is squeezed so much, the ejection fraction goes down and down and down. Yeah, you can pass out and die from that, right? Slip into hypovolemic shock. So this is a medical emergency if you have something like this. These patients got to go to the hospital. Other causes of cardiac tamponades. So metastatic disease, we talked about that. That just causes us anything that increases pleural fluid. We talked about that. We talked about uremic pericarditis. We talked about all these. So anything that can cause increased pericardial fluid can cause tamponade if it gets bad enough. So that's exactly like a duplicate slide. Look at this one. Holy smokes. So this patient had severe cardiac tamponade from metastatic disease. So the cancer started getting worse and worse and worse. But the fluid started building up more and more and more. Why she didn't have this thing drained, I just don't know. I mean, usually this is very uncomfortable. They should have drained this long ago, in my opinion. 2.5 liters, that's ridiculous. 2.5 liters was taken out of the pericardium. They finally drained it. They just stick a needle in there, and they just drain it out. My wife had a good friend who just went through cancer and passed away, but she had to go every week to get her drained, her pericardial cavity sac drained, her pericardial cavity drained, and her pleural cavity drained from the cancer. She had lung cancer. So that's like crazy. How about some clinical findings for tamponade? Well, if you have a heart like this and you auscultate, what are you going to hear? Probably not going to hear any heart sounds. And you'll also have something called Pulsus paradoxus. Pulsus paradoxus and cardiac tamponade, they go together like peas and carrots, right? You remember that. Cardiac tamponade, peas and carrots, Pulsus paradoxus, not Kussmaul's sign. Kussmaul's sign, not peas and carrots. P for P, C for C, carrot. Hey, I just made that up. Yeah, peas and carrots. P for peas, carrots. They go together. Not Kussmaul's sign. What time is it? Do we have, let's see, where are we at? Oh, yeah, we got to keep going a little bit more. Let's go into Pulsus paradoxus. Peas and carrots. All right, so it was discovered, both of these findings were discovered by this dude, Kussmaul. And there's a sign. I've actually talked about Kussmaul's sign before. But Pulsus paradoxus was also discovered by Kussmaul way back in the 1800s. And he was examining a patient who had cardiac. Turned out they died. They had cardiac tamponade. But he noticed this strange paradox. When he was palpating their pulse, it would disappear, it would come back. It would disappear, it would come back while he was holding it. And he looked carefully and he noticed every time they took a breath in, the pulse would disappear. And when they breathed out, the pulse would come back. And then he thought, oh my God, the heart's messed up. So then he took his stethoscope, he auscultated the heart, and the S1 and S2 heart sounds were normal. So it wasn't the heart cutting out, because he thought, oh, the heart must be kind of rhythmically cutting out to produce that drop in pressure, but it wasn't. So a weird paradox, and it took him a long time to figure out the cause of this. And we're still not 100% sure, but we got a pretty good idea now. But it occurs when the blood pressure drops as the patient inspires. Blood pressure drops, can't feel the pulse anymore as the patient inspires. When the patient expires, goes back to normal, you can feel the pulse again. So remember, inspiration sucks blood into the right side of the heart. I've said that like a zillion times. Well, maybe not a zillion, but a lot. And why? Because when you expand the rib cage, it creates a sucking force, a negative pressure, and it sucks blood in to the right. It also keeps blood, it holds blood inside the lungs. So the left ventricle gets cheated out of a little blood when you take a huge deep breath in. So the pathophysiology of cardiac tamponade, because tamponade, peas and carrots, it causes Pulsus paradoxus. So it's believed that fluid in excess of 200 milliliters starts to squeeze the heart enough to screw up the ejection fraction. I don't even know why I have this slide in here. We were just talking about this story about what the heck is Pulsus paradoxus. And so here's the deal with it. So in cardiac tamponade, the walls of the heart can expand. When you take a deep breath, you're sucking blood into your lungs, or you're sucking blood into the right side of your heart. Normally, when you suck blood in, like everybody do it right now, take a deep breath. Okay, you just sucked a bunch of blood, extra blood, into your right side of your heart. And remember, we talked about that yesterday, where the blood is not going to pass through the heart. Remember, it delays the valves, so you get a splitting of the valves, the semilunar valves. But what else happens is your right heart stretches to accommodate that extra blood. Now, what if you have cardiac tamponade? How can you stretch out the right heart when there's something preventing the heart from expanding? And that's the whole problem. So you don't. So something's got to give. You're sucking blood in. There is something that can expand. And that something is the interventricular septum. The interventricular septum is pushed into the left ventricle, right? So that decreases the volume of the left ventricle. And then, therefore, when you try to fill the left ventricle, it's not going to get much blood. You're already holding back blood from the lungs anyway by taking that deep breath. So the ejection fraction is going to be significantly decreased if you can't expand the fibrous pericardium. And as a result of that, you get a decreased left ventricular volume because the interventricular septum is pushed in. Let's look at a picture. All right, so here's a normal heart. So this guy's taking a breath in, or I guess he's blowing out. So now he's taking a breath in, and here comes the extra blood. They could have made this more obvious, I think. This is not a great drawing. But this is swelling up, and that's fine because this is slightly stretching out. They should have way exaggerated that. That's fine. The pericardial cavity is right here. It's not filled up with anything. Right, so interventricular septum is right here. That's not being bothered at all because we can stretch the right heart. We can stretch the wall of it right out. But here's a patient with fluid. He's got tamponade. He's got tons of pericardial fluid. When he takes a deep breath, there's nowhere for the blood to go. So instead, it pushes the interventricular septum right into the left ventricle. And look at this size difference. I mean, it's still subtle. I don't know why they drew it like this. But you can see it is much smaller here. And so now your ejection fraction is going to be tiny. A little bit of blood comes out compared to lots of blood. There's a big glob of blood. There's a little glob of blood. And so that's going to decrease your pressure. See how that works? All right. With the volume of the left ventricle decreased, the ejection fraction drops the blood pressure, and while you're palpating, you can no longer hear a pulse. So what's the definition of Pulsus paradoxus? How bad does it have to be to start getting worried? Well, if the systolic pressure, you can measure it with a cuff, blood pressure cuff. If it drops by more than 10 millimeters of mercury during normal inspiration, as measured via sphygmometry, you got Pulsus paradoxus, right? Well, how do you know? How can you measure 10 millimeters? Let's show you how to do the test. Let's test for Pulsus paradoxus. I keep threatening. I'm going to put this in that lab one of these days. Probably should take this out because you guys are already brainwashed on how to do blood pressure the way they want you to do it. So I should probably just substitute this in maybe next quarter. But anyway, because it'd be easy to do. So put the patient down, put the cuff on, pump them up, find the cutoff pressure, right? You're palpating the brachial artery, pump up. Okay, let's say 120. Oh, the pressure disappeared. Okay, well, that's 120. Now keep going, 30 millimeters above. All right, you're supposed to take the cuff off and, that stuff to do it the way the board books say, but go up to 150. And now slowly let the air out and get ready to shut that valve off. You've never done this before. You got to shut the valve. So listen. 140, don't hear anything. 130, don't hear anything. 120, boom. You hear the first boom, which is Korotkov 1. Close the valve right there. We want the cuff to be inflated exactly to that 120 millimeters of mercury. And now you hang out and listen. What happens? Okay, is it a boom, boom, boom? They breathe in, boom, boom. Nothing happens. Okay, they don't have pulsus paradoxus. But remember, we have the valve closed. They have 120 millimeters of pressure in that cuff. But what if you hear boom, boom, and you look at them and they're breathing, and now they're breathing in, and now they're breathing out, boom, boom. It comes back again as they breathe out. Then they breathe in, it disappears again. So now sounds like they have pulsus paradoxus. But to confirm, drop down. If you're at, where were we? We're at 120. Okay, so now to test it, you're going to drop down to 10 millimeters, drop down to 110, close that valve again. So let a little air out, close the valve at 110 and listen. You still should hear Korotkov 2 going boom, boom, boom. But if it still disappears when they breathe in, they have pulsus paradoxus, 10 millimeters of pulsus paradoxus. They need to go to the ER. You could even go further, see how bad it is. Go down to 100. Can you still hear the pulsus paradoxus? These are really bad signs. Send them to the ER just to be safe. Got it? That's the pulsus paradoxus story. Everything I just said there. See how bad it is. Everything I just said. Let it out 10 more millimeters. You can read through this. If it disappears again, they got pulsus paradoxus. You could go down even further. Okay, now we got one more thing to explain, and we're out of here. So, what about chronic obstructive pulmonary disease? What's that an AK for, really? That's the parent category. I've said this before. Make sure you know this. So that's chronic bronchitis and emphysema. Patients with chronic bronchitis. Why? Because there's always a mix of the two. It's very rare for you to have 100% emphysema without having some chronic bronchitis. So they lump them into that category. But these patients have trouble getting blood through the microcirculation of the lungs. The microcirculation is screwed up because of various reasons. Fibroblasts, or extra scar tissue in there, destruction of the alveoli, things like that. And so you can't get blood through the microcirculation well. Well, we already said that if you take a deep breath in a normal person, that holds the blood in the lungs more than normal. So as you're breathing in, not a lot of blood flows out of the lung. Well, plenty of blood flows out of the lungs, but it holds some of the blood in. And so now the double whammy is people with COPD, no matter how they're breathing, they can't get blood out of the lungs very good. So when you take a deep breath in, it holds a lot of blood in the lungs, so much blood that the left ventricle doesn't fill well, and you get a decreased ejection fraction. There's nothing pushing into the interventricular septum here. There's just not a lot of blood coming into the heart because they already can't get blood out of the heart because of the COPD. And when you take a deep breath in, the negative pressure really holds the blood in the heart. And so they also demonstrate pulsus paradoxus. Okay, are we good with that? Everything I said. What are some of the causes of pulsus paradoxus? Really, peas and carrots, cardiac tamponade. Here's another pea and carrot, C. Oh, that works pretty good. Won't forget that now. Pulsus paradoxus, COPD. There are some other causes, but these are the two big ones, and we're going to leave it right at that. Kussmaul's sign. My brain has had it. I'm sure your brain has had it, so let's call it a day. We will see you on Tuesday. Let's see, Monday, we will not have endocrinology Monday because of the holiday. So we got a day off. All right, see you guys. Have a great, what is the holiday? Memorial Day, I think. Have a great Memorial Day weekend.